Welcome to the session. Hello. Hello. Today my topic is CT MRI evaluation of GI cancer. ঠিক আছে? ঠিক আছে? হ্যাঁ। I will cover the carcinoma esophagus, carcinoma stomach, colonic carcinoma, rectal carcinoma.
আরো কাছে আসতে হবে।
হ্যাঁ। ঠিক আছে? ঠিক আছে? হ্যাঁ। And anal carcinoma. ঠিক আছে? Mainly, I will talk about the staging system of GI cancer. Carcinoma esophagus. Esophageal carcinoma is globally the seventh most common cancer. This is the division. I will go forward. The CT has poor sensitivity for detection for superficial lesion, and it appears as CT scan, thick, irregular, enhancing esophageal wall, causing luminal narrowing. Morphologically, it appears as a circumferential wall thickening, polypoidal lesion, or overhanging margin, or sometimes appear as a ulceration. AGS cancer staging is mainly, I will highlight that T1 it is invade the submucosa, T2 invade the muscularis propria, T3 invade the adventitia. The N category, which include N1, the 1 to 2 locoregional lymph node, 2, 3 to 6 locoregional lymph node, and N3 more than 7. M category is M0, no distant metastasis, and M1, distant metastasis. Radiologically, it is CT scan, better performance for higher stage lesion like T3 and T4. And in case of the T1, it can appear as a subtle wall thicken, which may missed on CT scan, which is better depicted on PET scan. This is a T2 lesion, which appear as a circumferential wall thickening with smooth outer wall. T3 lesion appear as a circumferential wall thickening with associated paraesophageal fat strandings. CT scan has a most important role for the T4 disease, like local invasion, aortic invasion, tracheobronchial invasion, and pericardial invasion. This is the lesion circumferential wall thickening, which invade the mediastinal pleura. This is the circumferential wall thickening in upper esophagus, which invade the trachea. This is invading the aortopulmonary window, which causing ultimately the laryngeal nerve pulse. This is the stage 4B lesion, which invade the aorta, that is the area of contact is more than 90 degree. This is the lesion showing the tracheal invasion. This is the esophageal carcinoma complicated by aortoesophageal fistula formation. Regarding the regional lymph node detection, there is a tiny paraesophageal lymph node which may not be detected on CT scan. It's better depicted on PET scan. This is the enlarged periesophageal lymph node and hilar lymph node. This is the N3 more than 7 paraesophageal, including the mediastinal and hilar lymph nodes. For the distant metastasis, it appear as a pulmonary nodule, which is associated with the circumferential wall thickening. This is pulmonary metastasis, and this is the case of showing the hepatic metastasis. So, our reporting checklist should include the site, craniocaudal extension approximately, the secondary effect, that is the luminal status, and for the stage 4 disease, bronchoesophageal interface, aortoesophageal junction, GE junction involvement, and lymphadenopathy. This is the case in our institute, which showing the carcinoma esophagus polypoidal lesion with smooth outline. There is no paraesophageal fat standings. This is the case showing that circumferential wall thickening with paraesophageal fat standings. This is the another case showing there is a circumferential wall thickening which invading the mediastinum. Now the carcinoma stomach. Carcinoma is a reported accuracy more than 90% in MTCT for detection of gastric carcinoma. But in case of the positive contrast agent using marks the wall enhancement, so that we are using the mural that is water as a neutral contrast agent for depict the wall enhancement. CT is the modality of choice for staging. Here morphologically it appears as a circumferential wall thickening or polypoidal mural thickening or as a mass lesion. Lineatus plastica is another variety showing the diffuse wall thickening which is extending from the cardia to antrum region. And this is the mucinous variety showing that multiple punctate lesion along with the wall thickening. Now the age-associated cancer staging, which again it is T1 is up to the submucosa, T2 is up to the muscularis propria, T3 is the invading the connective tissue adjacent to the subserosal region, and T4 is invade the subserosa and serosa. Now the regional lymph node, N1 is 1 to 2 regional lymph node, 2 is 3 to 6, and N3 is more than 7. Distant metastasis in M0 is no distant metastasis and M1 is distant metastasis. For staging, T1 actually T1A which is not CT scan is not capable to detecting the T1A tumor. This is incidentally detected as a tiny polypoidal lesion. T1B, which is shown as a focal wall thickening but preserved, there is a hypodense submucosal layer. T2 is showing as a polypoidal lesion which invade the muscularis layer without fat strandings, which is better depicted on PET scan. This is T3, which is showing there is a circumferential wall thickening associated with transmural enhancement. T4A, there is a invasion of subserosal layer. This is T4B, which infiltrate the transverse colon through the gastrocolic ligament invasion, and this lesion is invading the anterior abdominal wall. This is the tiny perigastric lymph nodes, and this is the enlarged perigastric lymph nodes, which is categorized by their number. Now the distant metastasis is appear as a circumferential wall thickening associated with lesion in the liver, which is appear as a distant metastasis. And this is the another lesion showing the circumferential wall thickening in the stomach and distant metastasis to the both ovaries, which appear as a solid enhancing lesion, which is known as the Kuchenberg tumor. So our reporting checklist should include the site, length, mural wall thickness, morphology, perigastric straddlings, peritoneal involvement, adjacent visceral involvement, and locoregional involvement, of course ascites and metastasis. This is our case which showing there is a lesion into the fundus which is ultimately invading the splenic hilum. This is another case which is there is a large polypoidal lesion which invading the stomach. This is the diffuse wall thickening which is extending from the cardia to antrum, which is this is the known case of linitis plastica. Now the carcinoma colon. MRI is the good sensitivity for tumor detection for the staging purpose. Morphologically, it showing as a diffuse circumferential wall thickening or polypoidal lesion, or it may appear as a apple core appearance. Now staging, it is T1 is it is invades the submucosa. T2 it invades the muscularis propria. T3 it is invades the pericolonic tissue, and T4 serosal surface invasion. Lymph node, and this is the distant metastasis. I will show you in figure. This is the T2 lesion, which is showing as a polypoidal lesion, but there is no adjacent peri-lesional fat stranding. There is a clear adjacent area. This is the T3 lesion, which shows there is a peri-lesional fat stranding and fat infiltration. This is T4A lesion, which showing that invades the visceral peritoneum. This is T4B lesion, which infiltrates the adjacent structure and invading into the urinary bladder. This is the nodal perigastric pericolonic lymph nodes, which is vary from size may be vary. This is metastasis, which involving the ascending colon and distant metastasis to the liver. Omental caking may present as a distant metastasis, and peritoneal nodules may be seen. So our reporting checklist should include the site length, mural thickness or morphology, pericolonic fat stranding or transmural extension, peritoneal involvement, adjacent visceral involvement, locoregional lymph node, and ascites. This is one of our case showing there is a circumferential wall thickening with apple core appearance. This is the lesion which invade the visceral peritoneum, and this is the carcinoma colon. It's affecting the splenic flexure, and there is a pericolic fat stranding and invading the stomach. Now the rectal carcinoma. Rectal carcinoma, as you know, it is extend from the rectoanal junction to rectosigmoid junction, which is marked as a sigmoid takeoff. Another important thing is the peritoneal reflection, which is appears as a thin strand. It is mainly present in case of the upper rectum and anterior part of the middle rectum, and for the lateral portion of the middle rectum and lower rectum, it is surrounded by mesorectal fascia. So it morphologically it appears as a polypoidal lesion, semicircular lesion, or circular circumferential lesion. It may appear as a intermediate signal intensity solid looking lesion, or sometimes may appear as a mucinous, which is appear as T2 high signal intensity. For the lower rectal carcinoma, we have to mention the sphincter status within the report. For the staging disease, the T1 is invade the submucosa, T2 is invade the muscularis propria, and T3 that is invades the muscularis propria and having the different grading system. I will show you in the picture, and the T4 has the directly invade the adjacent structure or visceral peritoneum. This is the N0. N0 is no regional lymph node. N1, 1 to 3 regional locoregional lymph node. N2, 4 and more. Distant metastasis, which is include the M0 no distant metastasis, M1 distant metastasis, and there is a subcategory. Actually, for T1 and T2, the MRI could not differentiate this T1 and T2. MRI has specific role for the T2 and early T3. For T1 and T2, it is limited as a bowel wall thickening, and there is a intact muscularis propria. But in case of the T2, there may be associated with some speculation, which due to the desmoplastic reaction, but still it is on T2. In T3 variety is extend to the transmural extension, and we have to take the measurement to categorize as a 1, B, C and D. This T3 AB is, that is the less than 5 millimeter, and T3C and D is more than 8 millimeter, which is calculated for the treatment purpose also. Then we have to calculate the distance, short distance to MRF. We have to calculate the distance from the mesorectal fascia to tumor as a shortest distance. If it is less than 1 millimeter, then the lesion will be in threat. This is the mucinous carcinoma, which invade the visceral peritoneum. It is stage 4A. Stage 4B, which is invading the adjacent structure, like in this case, this is the cervix of the cervix, and here it is invading into the prostate. Now, another important thing is the extramesorectal venous invasion, which is not included in the staging system, but for the prognostic purpose, it is very important. That is the tumor signal intensity, which is present within the adjacent vessel structure. And for the lower rectal carcinoma, we have to mention the status of the sphincter. This is the locoregional lymph nodes, pericolic and presacral lymph nodes. Metastasis, which is present into the lung as well as into the liver. And our report checklist should include the length of tumor, distance from the anal verge or anorectal junction, tumor relationship to the peritoneal reflection, which is mainly for the upper and part of the middle rectum, and tumor morphology, invasion margin in clockwise phases, and T stage, depth of tumor invasion, which should be include T3 AB less than 5 millimeter or more than 5 millimeter, and there is a shortest distance to MRF. Extramural venous invasion should be included in the report system, and mesorectal and extramesorectal lymph node we should mention in the report. For the lower cancer, sphincter status should be included. This is the case in our institute where the upper rectal cancer associated with the intussusception. This is the stage 4B cancer, the carcinoma in the mid and upper rectum invading the adjacent urinary bladder. This is the carcinoma of middle rectum showing the mucinous component. The carcinoma anal canal, the anatomy is a little bit complicated over here, and this is the one is indicated, that is internal sphincter, two is the intersphincter space, and 3 is the external sphincter. You know, the one that is intersphincter is the continuation of rectal musculature from above. MRI is the modality of choice for the detection of the anal carcinoma. We should, in case of the, if it is a little bit more than 1 centimeter, it can detect as an intermediate signal intensity. But if it is subtle change, then we have to detect this lesion on DWI. The staging for T1 is less than 2 centimeter, T2 tumor is 2 to 5 centimeter, and T3 is more than 5 centimeter, and T4 is any sign. locoregional lymph node, which is including the inguinal, mesorectal, internal iliac, and external iliac. And for the common iliac nodes are categorized as a M1, which is metastatized. The M0 no metastasis, M1 distal metastasis. Now this is the T1 lesion, which is appear as less than 2 centimeter, so it's categorized as a T1. This is T2 tumor, which is more than 2 and less than 5 centimeter, so it categorized as a T2 lesion. Now this is a more than 4 centimeter, and this is categorized as a T4 and a T3. Sorry, and T4 lesion is any size, but it invades the internal sphincter, intersphincter space, and external sphincter. So our reporting checklist should include the size, the longest possible length, the tumor location which invades the internal sphincter or intersphincter space or external sphincter, and tumor extends to rectum or not, tumor morphology, and tumor invades the levator ani muscle or puborectalis muscle or not, and lymph node status. This is one of our case showing the flags of calcification is a mucinous variety. This is also a case of anal cancer with mucinous component. So thank you. There is only the staging system.
Thank you very much, madam. I hope all of you have enjoyed this session as well. So, madam, so dear audience, if you have any question to Madam Taslima, madam, you can ask freely. Madam will appreciate the question. Any question from the audience? Not yet. So I think there is no question. So by this we are concluding the session for today.